Going to see if I can see some of your comments. My name's Charlotte Williams. I'm an alumna of St Anne's College, matriculated in 1997, biochemistry, and I currently work for the NHS as a strategy director for a large hospital in Essex, Mid and South Essex NHS Foundation Trust. And I've been asked by the college to talk to you a little bit about what life's been like in the NHS over the last few months responding to the COVID-19 pandemic, and also about, I suppose, a little bit about what we're thinking going on in the future with recovering from that. Oh good, I've got some messages, you can hear and see me. Fantastic, that is brilliant. Much as we spend our life on these things, at the moment it's really hard to tell whether or not they're working, so so great and good. Thank you very much for joining me. So I'll talk a little bit about what I do, I suppose, and what the COVID pandemic has meant to me over the last period, and then you can just ask me some questions about whether it's helpful. And I think we've got until about 8 o'clock. But obviously if I get very boring or you run out of questions before then I'm sure we can all go off and do something else, but it'd be really great to hear your thoughts and the kind of things that I might be able to talk to you about. So since probably about the middle of March, when we moved into into the delay phase around the pandemic planning, you might all remember when Chris Whitty and Boris Johnson started appearing behind lecterns across the UK to inform us about our need to move to a more active response to the coronavirus spread across the world. My life changed quite a lot. So before that I was mainly working on long-term planning, innovation projects, working to develop new models of care closer to home for patients in my role leading strategy, and had quite a good role, but it took quite a long time for things to happen. So it's kind of, you put plans in place and spend a long time accessing funding and understanding how outcomes would improve for patients, and generally I would wait sort of 3 to 5 years to see the results of the kinds of projects that I was involved in. But that all changed when we set up our level 4 major incident response planning to what's called a rising tide major incident. So something we can see on the horizon and we know is going to have a destabilising or disruptive effect on services. And I'm one of the executives on call for our organisation, so I then joined round the clock, essentially an incident response gold command. Have the fantastic militaristic terms that we use for how we respond, and the NHS, I have to say, is pretty fantastic at responding to incidents. It's some of the things that we're very, very good at on a daily basis. We manage demand and capacity in real time. We manage some very traumatic issues, and our staff on International Nurses Day, I should say today, our nursing staff and other colleagues across the organisation really have fantastic resilience and know what to do. So when things go wrong, we tend to know what to do. So we set up our usual processes, made sure that we had surge plans. We were learning from Italy, we were learning from China, we were looking at the research every day. We had clinical advisory groups talking to doctors in London. So being in Essex, we're kind of on the edge of London, but we could see that the pandemic was going to peak in London first. We had epidemiological modelling. We were trying to make ourselves as well informed as we possibly could be, and we did quite a lot. You know, we were thinking at that time that we were going to be completely overwhelmed. I think that's pretty fair to say. Most people had a sort of sobering minute as we sat there and kind of talked about what we needed to do. So our nurse director, our medical directors, those who lead on for our medical engineering, for pharmaceuticals, for kind of pathology and laboratory testing, all kind of sat around thinking it's pretty horrendous and it's probably going to be pretty bad, and what can we do? And so we kind of knew that what the worst could be, and we were very much given a lot of freedom nationally by NHS England and NHS Improvement, a really kind of empowering message actually to our local leaders to say whatever you think that you need to do, talk to us about it, but ultimately you need to really pull the stops out and try and make sure that the things are in place and what they need to be. And at that time we were planning for a lot of patients who are going to need intubation, so need to be on ventilators, hundreds of patients probably at that point, and we might need to think quite dramatically about the places we could accommodate those patients and the staffing that we would need. So really practical things come into play then, like how many machines have you got? How many machines have you got to ventilate people? How many filters you got that go inside those machines? How many things have you got to deliver drugs to those people? All those really practical things. How many staff you got to know how to use those machines? How thin can your staffing get and still be safe? And because all this was fairly new to us and the disease wasn't well characterised in terms of the kinds of therapies that might be effective to combat its consequences, because obviously there was no treatment that was understood, we're really learning as we go. So a lot of the time it'd be, well, there must be national guidance on this, which is what we normally rely on at local level, and there wasn't always national guidance. So it was sort of, well, do we make up our own guidance here, or do we wait for a line from the centre? So I think common sense prevailed in general, but in terms of a management challenge, it was probably something I'd not encountered before, in terms of needing to use to keep the best interests of patients at heart, and kind of use the guidance that you've got and innovate where you can, with the freedom to do so, but understanding the very constrained situation that you're in and the kind of risks that you can place people under. So we started to think very quickly about what incentives can we bring in, how can we make life better, so things like free parking, free meals in the restaurant. That all sounds easy to do, but then you're like, well, how many £100,000 is that? Where are we going to get the money from? Is that something staff are going to value? How do we help people, make people's lives easier? So all of those little pain points that had been difficult to negotiate before, suddenly it gave us the freedom to think about those things differently. So a kind of very major incident type response, centralised command and control. We were focusing on getting as many people into ITU as possible, and then we waited. Essentially, we waited for the demand to come, and what actually happened in Essex, where I work, certainly for at least a couple of weeks, was nobody came. So we had very low footfall. I think the public had really heeded the message that there was a dangerous disease out in the population, and so to stay away. So we saw demand in the emergency department really going down, and I think that has continued to do so. So across our sites, I think we saw about 65% reduction in people coming to A&E or being referred by their GP up to A&E, and I think our general practice colleagues saw something similar. So it was quite eerie coming into a major incident response on a daily basis and there not being any ambulances outside Basildon A&E department. And I've been on call at Basildon for many years, and we normally would have 350, 400 patients a day coming through that emergency department. So it was quite odd having very intensive plans for massive capacity, for very sick patients, for staff fearing the worst and actually being very quiet. So that in itself was a challenge. But then obviously the patients did come early April, and then there's a whole other set of challenges then in terms of what do we do if it's we've got 3 hospital sites, and one of them is much closer to London and much more of an obvious demographic, and that got a lot busier before the other sites, so we were able to support the team there with doctors and with patient transfers across our area. So it was really an example of how working together makes us more resilient. And we've been able to put in some really much more relaxed and integrated working arrangements as part of the COVID response. And a lot of people saying things like, well, we can do this because of COVID. But actually, it makes you think, why don't we do this all the time? Why do we need a pandemic response for us to work together better and more seamlessly, and to see some really selfless behaviour that we've seen over the period from institutions that would have found that difficult before. So it's been quite enjoyable from that sense, and the level of bureaucracy that's moved out of the way, I think, is an opportunity for us to learn. And we're spending a lot of time now reflecting, now that our surge is over, so we have come back down into a sort of, we're calling a steady state environment. So we've still got a number of people in intensive care. Probably, our intensive care units are still surged up to possibly kind of double the capacity that they would normally be at. But it feels more under control and more predictable and more manageable. And we are allowing, able to stand down some staff and allow people to go back to the jobs that they would have been doing before. But the next challenge for us is this, living with an infectious disease in the population, which is going to mean that we have to segregate our patient groups and also our staff and our facilities in a way that we've never really done before. So that's the next challenge for me, and I have been appointed what I think was, my boss told me, was a battlefield promotion. So again, a military term, to lead what we're calling our future programmes, so our resetting of services following the COVID surge, into a new model of care that allows us to retain the resilience and the surge, because we do not know really what's going to happen in terms of public behaviour, the R factor that we all hear about so much on the briefings, and what that's going to mean in terms of numbers. So we have to be quite conservative and allow quite a lot of capacity for surge and super surge back if that should happen, if we should see that infection rate going back up again. And we still have a lot of vulnerable people in the population, but we can maximise on the things that we've changed for the better. So we have a kind of no going back policy, which is if we put something in for COVID that was better than what we had before, we should never go back to what we had before. And how we invest in a way to build on that and make that better. So I think the unknown for us in the NHS is whether that public behaviour to how they've used services will last or not. So it's probably a concern to us that there's a deficit of care in the population at the moment, that 65% of people went away from emergency department. A lot of those people did need to come to emergency department or will need to come to the hospital. So you'll have seen the public campaign about the NHS is here for you, we can keep you safe, do come and seek help if you want to, and seeing trends going down in things like acute coronary syndrome or stroke symptoms. Those things are quite worrying about what that might mean in terms of the population. But obviously a lot of other people who used to come may not need it to have come in the first place, potentially. And also because of the lockdown, we've seen a reduction in things like trauma, violent crimes and things like that, which have had an impact obviously on demand. So we don't really know what the shape of the kind of NHS's future customer base is going to look like, I suppose. So that in itself will be of interest, and we will analyse what's going on in our organisation every day and try and learn and adapt to that in a new way. So it's a really interesting intellectual challenge for me, and I think it's been quite an exhausting experience. I can't think I've had a day off since Christmas, but there will be a day off on the horizon soon. And really been kind of through it with colleagues and got to work in a new and interesting way. Not always able to keep up with the news, which is perhaps a good thing. But I think if your NHS is still here for you, we're working really hard to adapt and learn from COVID and continue to support those who come to us. I think it's quite interesting that there's quite a lot of debate about whether it's economy versus the kind of health of the population in this COVID world. And I suppose if you do what I do for a living, you've got to feel that protecting the population is the right thing to do. So I hope that we continue to do that and to prioritise keeping the most vulnerable in society safe. And we'll still be here looking after you all. So that's my bit of talk. I don't talk for too long, but I'm very happy to answer any questions anybody wants to post in the comments. I think I can see them all here on my phone, so do ask me some questions, otherwise I'll be doing nothing for quite a long time. See if I can see one. Can the public do anything to help the NHS at the moment, and if so, what can we do? Yes, I think the NHS needs your moral support. I think continuing to advocate for a good settlement for the NHS, obviously in terms of recognising that it does need to be well staffed and well resourced. I think it's been prior to COVID, our main risk on a daily basis was whether we're going to have enough staff, because of difficulties in doing so. So anything you can do to advocate for that and to support the sort of attractiveness of the NHS, and also the social care sector. Just as many people work in care and social care as they do in health. And that our staff are our greatest asset and have been absolutely phenomenal during this entire episode. So and if you know anyone, or anyone who's interested in working for the NHS, tell them it's a good thing. We need them. It's a great career, and I think the value that we've seen in the public for the NHS and care workers and key workers has been really helpful at keeping up morale. So I suppose we're continuing to do that. And just use the NHS appropriately. We're here to look after you if you're not well. We're here to help you learn how to look after yourself if you have a condition, and to give you treatment where necessary. But just, I suppose, being responsible with that. I won't make any political statements, but continue to support your NHS locally and nationally. Okay, right, I've got some questions here now. I'll see if I can read them. But it's striking that we have managed to maintain spare capacity in the sense of care, not for the need Nightingale hospitals. Yeah, we have. Hang on, I've got to click on that. I can't see the bottom of the comment. Horrifying how just many of these outside hospital settings. Why? Oh, that comment just keeps disappearing. Oh. So so Nightingale hospitals is an interesting thing, because we've put all these big hospitals in and not use them. I think that was totally the right thing to do. If it were me and I was looking at the modelling numbers that we were seeing on sort of early March of what COVID could have meant, and to be fair, at that point there wasn't a huge amount of validated, peer-reviewed kind of publications about it, and still isn't, but it's emerging. That's what I would have done. I think that was the right thing to do. Was to prepare for that. We had to be able to offer COVID care for everyone who needed it, and at that point we were going to need a lot of excess capacity. So I think fundamentally that was the right thing to have done. And the fact that it hasn't been used, well, it's like an insurance policy. I suppose you never had to cash it in. So that's, in the grand scheme of things, you could say, well, it's a lot of money, but it was money used in the right way, and actually it's not being wasted, and we learned a lot from it. And we needed to do that at that time. I think when you're responding to a major incident, you just got to act on the information that's available to you at the time. So I think that's true. I think the death rates, the absolute numbers of deaths obviously here are higher than recorded in some other countries. Why is that? I'm not able to say exactly. I think obviously the elderly and more vulnerable population are obviously more susceptible to the consequences of COVID-19, and that therefore those who are resident in care homes, for example, whose kind of median time to the end of life is quite limited anyway, are going to be more susceptible to that, and unfortunately, particularly with quite a mobile care workforce, it's probably quite hard to control transmission in those settings, and you're going to have a number of people, as I say, who are more susceptible at risk to that. So I don't really know overall. You'll have to look more at the causation data when that's available. I think at the moment all we can see is various trends, and we're making inferences about it. I think planning for ITU capacity, if you were looking at what was happening in Italy at the time, that's exactly what you would have done, and exactly, I think, the right thing to have done. Let's see what else we've got. For lockdown, cancer referrals are down by up to 80%. I'm sure it's the same for other illnesses. Will this create a long-term issue for the NHS? Quite possibly. We, as I said before, we are worried about the downward trend in some presentations of disease, and Cancer Research UK, I think, has put out some information about that, about the number of people that we might not be seeing, and also because of the risk of certain things, particularly what we call aerosol generating procedures. So when a sort of spray is created by doing a procedure, the advice has been not to undertake those procedures because of the risk of COVID exposure. So that means that certain procedures that we would have wanted to do, we've not been able to. So that has also deferred the treatment for some patients. But it's all about managing the risk. And I think as we go forward, we're going to have a conversation with the public about an educated conversation about balancing those risks of seeking that treatment and coming forward, the consequences of that, and the risks of not doing so. I think we know an awful lot more now about how to separate and segregate our facilities and our staff to keep people very safe. We've also got a lot more testing now, so the massive expansion in testing, you'll have heard about it on the news. In high risk areas such as cancer treatment, we test not only patients but also staff, so that we know that even staff, if they're asymptomatic, are not going to transmit an infection to patients who may be immunocompromised. We don't do that uniformly, but in high risk areas we do. And obviously the understanding around which personal protective equipment is required and things like that. So hopefully, if you know anybody who is worried, they should come forward, because we can absolutely keep them safe, and COVID should not be a reason for them not to come forward. But yes, it is a concern, and we're actually doing some modelling at the moment to understand what might be the additional unmet need in the population as a result of people who haven't attended with signs and symptoms. So what else? Things that I thought you could have been doing all along, but it took COVID to prompt us to do them. Can you give us some examples? Yes, really interesting basic things. So there's things like information sharing. So I don't know why, but we always used to have problems with giving people access to people's data systems. I think either no one had ever thought to ask, or no one had been sort of prepared to go through the governance and approval processes to get these things signed off. But we needed to move all of the blood tests, routine blood tests and things like that, off the hospital site, because, you know, people still need blood tests, but don't need to come into the hospital where there you know, obviously lots of patients who are receiving treatment for COVID. So we just had to open up some systems, really. And people said, oh, okay, we can do this, but just do this for COVID. Why? Why is that a problem? A GP can print off a blood form or send somebody up to the phlebotomy clinic. So little things like that, but also bigger things. So there's been a suspension of some elements of legislation during COVID. Things particularly between health and social care about who's responsible for paying for care and treatment, whether that's health or social care, which some people may be familiar with that idea of being something that was bed blocking in the past, that patients couldn't get out of hospital because there was an argument over whether or not they were going to be funded by healthcare or they're going to be funded by the social care and local authority. The changes around that have meant that you just get the patient out, worry about it later. You know, we'll just pay for it, just worry about it. And it'll be really interesting to see whether in the long run that's been any worse than what we had before. What we have seen is a real improvement in the length of time people are spending in hospital, up to sort of 20 or 30% improvement in some areas of the amount of time people are spending in hospital because of an accelerated pathway out into social care. And that's because I think everybody's been told, don't worry, we'll sort it out later, there will be money. And we were very clearly advised not to let those kind of bureaucratic things get in the way. And not only does that change the care for that immediate patient, but it changes the way everybody thinks about everything. So we were able to put in more centralised systems around identifying the capacity that was available for patients, standardising a lot of the paperwork, things that, you know, really, there's no really good excuse not to have done it before, other than the fact that everything else got in the way. So those are exactly the kinds of things that we want to keep hold of and not go back. So hopefully that appetite will stay with us. I can't comment on Virgin Care, that somebody's asked me. We have Virgin Care as the current supplier of children's services where I'm currently sitting to my own children, so I better not comment on that. What else? Do I think consideration be given to the capacity of testing centres within the UK? Yeah, I think the more testing you have available, the more confidence I think people have, both in terms of our staff and patients and the public, because obviously a test is right at that point in time, but we don't know enough about the disease at the moment to understand how its immunity works, and also because of the high prevalence of asymptomatic people. So I think the view at the moment is of 100 people with COVID, 10 of them will be severely ill, 60 will be mildly ill, and 30 will be asymptomatic. and some testing from other countries has indicated that that's it can be a problem. The asymptomatic population could be a problem and could be behind some of the early transmission in higher areas. So in healthcare, for example, of the healthcare workers who died, then they are not in the areas of highest clinical risk. So in ITU anesthesia, for example, they tend to be in the non-critical care areas, which may indicate that they were less, obviously the PPE is less, and so the possibility of transmission from asymptomatic people may be higher. Now, this is all just theory. I don't know whether any of that is proven yet, but I think the more testing that you can have and have available and have repeat testing, and the fact that fundamentally on a really practical level, if everybody has to self-isolate for 7 days or potentially 14 days, because they may have COVID, they can't work for us. So we've been lost. I mean, we have 14,500 staff across our organisation, and sometimes we've had 2,000 unavailable to work because of COVID related reasons. So that's a huge number of people not available. So the more testing that we have practically as well, that we can discount people as having COVID or members of their household from having COVID, then more quickly they can return to work and have confidence about that. And when antibody testing is available as well, I'm sure that will be really important, both to maintaining the service but also providing public and staff confidence. Are there any other questions? Will it be juggling between treatments and perhaps vaccines in future years? Yeah, I think it's really interesting watching the critical care doctors and respiratory doctors learning from each other during this process. So there have been some fantastic sort of conference calls with 100 people on them, all talking about how they're looking after people with COVID and what they're seeing and what they're learning and which symptoms, seem to be an issue. And one of the things that we realised in critical care quite quickly was a very large number of people also have kidney problems as a result. So we went from having a constraint around the number of ventilators that we could have to put people on and the oxygen supply to those ventilators, because that tends to be the rate limiting factor, to suddenly not having enough hemofiltration machines. So all of these kind of clinical findings were emerging as the patients were being looked after. So in terms of kind of treatment and care, I suppose, to manage the response to the disease, we're learning all the time, and things are improving all the time. And we know that with many complex conditions, the more patients you look after, particularly in the same place, the better outcomes they get. So probably, ironically, we'll get better at managing this disease as more patients go through, and we may start to get better outcomes as we consolidate and bring those teams together. So clinicians are fantastic at learning from each other very quickly in a practical setting. So that's been really good. I think a vaccine would be obviously brilliant, but it needs to be tested and to be safe, because I think there have been some difficulties with early use of vaccines in the past. And how we prioritise people with vaccination, I think will be a really interesting population challenge, and again will pose us another query for Public Health England about how that's prioritised, whether it's our shielded populations, because at the moment we still have in our patch around 30,000 people who are shielded and staying at home all the time, or perhaps those who are maybe making a contribution to the economy or something. So that's a question for somebody else other than me, I think, probably. Where are we? Let's have a look if we've got another question. Oh, there's one from Steve. Hi, Steve. Thankfully, it doesn't feel like there's been any no-go areas in the UK in the same way as northern Italian towns or Wuhan. Have you seen data suggesting certain towns are getting more affected or at risk of overwhelming the NHS and others? Yeah, so it's interesting. There was an article today actually in the Health Services Journal about the north of England, and that the disease tends to be targeting parts of the north more than has been seen in more southern England recently, and also the West Midlands I think was just as bad as London on a kind of pro rata basis at the start of the pandemic, at the kind of earlier phase. So I think it's interesting, and obviously we've seen other socioeconomic trends as well in terms of the kind of severity of the disease in different populations. I think it's going to be really interesting to see what the contributing factors are to that. and again, even across London, I think it's been quite heterogeneous. So, and in our east of England where we are, I think Essex has had several times the number of cases as Suffolk and Norfolk, which you could say is the London effect, but it can't simply be explained by being close to London. So yes, there's definitely data that I think is reasonably reliable that shows that the disease isn't uniformly distributed based simply on, say, population, for example. But whether we'll ever really know exactly what's driving that, I think it's probably going to be quite hard to tell in terms of the interplay of different factors. The main thing that we've been looking at in terms of trying to understand our planning response is the adherence to the lockdown. So that's the biggest factor that we use, kind of compliance factors. So it could well be that there's variance in the compliance factors with the lockdown in different parts of the country. I don't know. Certainly in Essex, I think we're tracking about a kind of 60% suppression rate. So that's pretty good compliance with the lockdown in our area. I think better than we had anticipated. So the British public can certainly be pleased that through their action we've been able to manage within our capacity. And I think it's no mean feat really to be able to reorganise the NHS to manage, even with, especially without the Nightingale hospitals in a way. That's I think been a credit to everyone involved that have been able to reorganise very, very quickly and manage within a matter of months, and now be more focused on how we actually put things back in a way that can just accommodate this really significant public health issue in our area. Has the crisis impacted relationships between clinicians and managers, and are you attracting the quality of new graduates who'd want into the NHS for the future? Thanks, Helen. Yeah, I mean, I do quite a lot of work with the NHS Graduate Management Training Scheme, because that's what I did as kind of big advocate for professional management in the NHS, and we have always had very good calibre of applicants, I think, because the course has been very attractive, but we just actually doubled the intake last year, but unfortunately the whole thing's had to be suspended now. It's really awful. So got no intake at all coming in September, so hopefully we'll be able to catch back up next year. I think the difficulty with us is retaining people in the NHS. I think it's quite often sort of seen as an attractive thing to go into, but then it can be a grind. It can be difficult. It can be the same thing year in, year out. Not this year, obviously, but and the kind of opportunities can be quite geographically boundaried and and fall into certain types of management. I've been quite lucky over my career that I've had quite a range of opportunities, but probably the thing that is good is I think Helen's point is the relationship. So certainly in hospitals, I've never really found that there was a difficult divide between management and clinicians. Certainly not in good organisations where everybody prioritises the quality of care and kind of patient experience and patient outcomes above everything else. I think in the financially constrained environment that we've always had, but certainly over the last 10 years or so, it's been difficult not to be cynical about things, or to find it very difficult to encourage innovation and ideas because of the feeling that there's no money. That has been really hard. But I think it's all about trying to inspire creativity and work and think about how we can work collaboratively with other parts. So we've done a lot of work with county councils to do interesting and innovative things. We've done some work with schools, working with industry, and so you can be creative and you can do a lot with it. And there's about 700 different professions in the NHS, so there's something for everyone. And I think during COVID, everyone has had a kind of shared experience. I wouldn't say it's the same experience for everyone. I think for some people, they've kind of been sent home and to have to sit at home and work at home for weeks and weeks. I've luckily not had to do that because I've not been, that wouldn't suit my role. But I feel privileged that I've been able to come to work and kind of be part of that effort and see that every day. And not had to go stir crazy at home with my kids. So I think it's something everyone will be like, oh, do you remember during COVID? Do you remember? a little bit like, do you remember where you were when the 7/7, whatever it is, happened, these things that everyone has a shared experience of. So I think it probably will contribute to additional kind of anecdotes and better relationships in the future as well. What's the NHS view on the Thursday clapping? Yeah, so I think generally people love it, to be honest. I think it's there's a lot of camaraderie in the service, particularly in the front line, and I think it's, why would we talk it down? It's a great thing, right? Let's show a bit of love, let's have a bit of fun. The NHS tends to be a bit silly. I think you might have seen our nurses in Basildon. They were on the the Ant and Dec show, I think it was, something, and they were interviewed on the Good Morning programme for dancing around in the theatres, and one of the doctors kind of came in and did a little boogie. Yeah, that was our team. So there's all that going on. I don't think anyone in the NHS would question whether or not it's the right thing to be doing. No, it doesn't mean everyone should be told to stand outside and clap, otherwise I don't care. Completely appreciate that, but I try and be on one of our hospital sites on Thursday night, just because it's nice to be there and to clap people face to face that I can see. Whether I would be happy about people clapping me in the street, I'm not sure, because it always feels a bit, when you're in management, it doesn't necessarily feel like it's quite as relevant for you. But definitely do it for the frontline nurses, social care, people who drive the lorries. What else have we got here? What time is it? I can't see the time. Don't want to spend too much time talking to you, more than I'm allowed. Waiting lists for surgery, a big issue before COVID. Do you think Nightingale hospitals could be used to clear operation backlogs? So I think the reason for maintaining the Nightingale hospitals is that they're part of the recovery plan. That makes sense. I think that certainly the one here in the Excel Centre, which is close to us in Essex, is not, you couldn't do operations there. It doesn't have operating theatres. It didn't have toilets at one point, because I think it was just designed for people who were essentially, in ITU. So they would need modification. But if the idea is that medical patients who don't need operations, that sort of thing, could go into the Excel Centre to create space in other hospitals, then that's a theory. I think it's quite difficult to operationalise that, and whether that would be the preference of local hospitals, I don't know. In London, anyway, I think more regionally it definitely could work. There are lots of things that need to come together to provide care. So you obviously need the facilities, you need the staff, you need the transportation, you need the consumables, the drugs, the portering, everything, the engineering. So a lot of those things have been invested in as part of the Nightingale hospital. So if they can be used, then I think that's great. I think the difficulty is they're not staffed. There's sort of another 70,000 beds, and we're struggling to staff the beds that we have got. So if we can resolve that issue, then I think that's definitely part of the solution. What we're looking at the moment is how do we consolidate services across our hospital sites, so we're not doing 3 bits of COVID care in 3 ITUs, trying to bring it together. And in that way, we can man that service more effectively and more reliably and with less protective equipment than if it's on 3 places. Protective equipment's a big rate limiting factor. And also it then means that the staff who are working on that unit don't have to cross over into other areas where there are patients who don't have COVID, because the sort of new infection control guidance is to segregate the staff and the patients into the high risk and low risk areas. And also, the more of the hospital estate we can make COVID free, then the more work we can do in terms of more lower risk care, such as chemotherapy or elective surgery or cancer surgery, that sort of thing. Otherwise we have to put in so much space and so much barrier that it becomes unworkable. So the Nightingale hospitals might work if you could make them specifically for either COVID patients or not for COVID patients. Then that would allow that separation. I just think the staffing is probably going to be the problem on that one. Have NHS staff been offered additional welfare advice or counselling or trauma therapy in the current situation? Yes. There've been quite a lot of staff wellbeing developments during COVID. I think it's probably been one of the nicer things, actually. So we've got in every facility that I know of across the NHS, there have been created kind of safe spaces where people can go. We had quite in kind of frontline hospitals, in most cases there are already normally sort of mindfulness areas where staff can go. And we run things like what's called a Schwartz round, where you can kind of talk through something hard that's happened to you with others in a confidential, safe space. Those things have been adapted to a non-face-to-face environment. There is always and always has been confidential telephone counselling services available. And we've also had some really nice things. So there's this thing called the Wingman scheme, which is where people who are redeployed from airlines come and do sort of hospitality services within the NHS. So we've got the Wingmen schemes, I think, from EasyJet or something in our hospitals at the moment. So you can go in and get some nice treats and that sort of thing. But yes, you're absolutely right that psychological safety is really important, and being able to debrief and to rotate out of high risk areas. And I think there's so much on social media, and there's so much out there about, unfortunately, NHS staff who haven't survived or have suffered severe consequences of COVID, that does contribute to the anxiety and the difficulty for people coming to work every day. So being mindful of that, and we've had members of staff in ITU, we've had a couple of members of staff who died, or who either worked for us or were working for us or have worked for us, who've died. And again, we're normally, as a caring organisation, do understand these things and do try to accommodate them as much as possible, but there's definitely been a concerted effort to do so more during COVID. And actually, a psychiatrist friend of mine has set up a service where psychiatrists who are self-isolated or who aren't busy working can provide that support to NHS staff within their area. Also on staff testing, we work with our mental health trust as well, so that if there are people need to kind of work with understanding if they've had a positive result or have questions about how to manage in that scenario, they can get that support. So that's certainly the "it's okay not to be okay" message has really come through over the last couple of years in the NHS. Yes, hopefully that answers your question. I noted earlier, suspending some of the typical bureaucracy involved in moving patients between the NHS and the care sector during the pandemic. Do you think a non-profit care sector that was fully integrated in the NHS would have led to better outcomes? Oh gosh, no, if you weren't recording this of it, but I don't know whether it's kind of a loaded question, but I used to say previously that the NHS didn't need any more money, we just need the money to go to social care, because a lot of what the NHS was doing was a consequence of social care needs in the local population, or the lack of social care. And I think we were getting to quite a bare bones situation as regards social care for the vulnerable in our area, or nationally, I suppose. So I think a more resource and more widely available social care sector would definitely be helpful. Would it have led to better outcomes? I don't know. I mean, I think if we're seeing the more vulnerable populations with less well controlled needs are more vulnerable to COVID, then potentially. But I suppose overall, in terms of health and well-being, I think you generally see countries that have a well-developed care sector that is well respected, resourced and well-staffed do better in terms of public health and well-being. So that's my response to that one. Let's see if I've got any other questions on here. I don't know. Oh, hang on. Will we get home testing kits, do you think? It was quite hard as well. Like, you had this kind of nasty swab for COVID. I'm not sure you'd want to do it yourself, but it has to be. You have to be able to do it well enough to get a good reading. Will we get home testing kits? Possibly you can't now though, so don't spend any money on anything that's marketed to you as a home testing COVID kit, because it won't be any good, I'm sure. But do I feel that COVID tests are working well and we have enough of them? They are now. I think in the early days there was some concerns about how reliable the results were, particularly on false negatives, but that was in the old style test, and quite often there would need to be a CT scan to corroborate, whereas now with the new PCR testing it's much more reliable, so they're pretty good. The issue that we've got is around what we really need is what we call point of care testing, so where you can just go and get a test and put it in a machine and get the result very, very quickly, so within a number of hours, rather than at the moment we're looking at 24 hours normally for the results to come back. So that will allow us, when a patient comes to emergency department, to understand whether they have a COVID positive or negative status, and then manage the facilities and the staffing to support their care in the most appropriate way. But unfortunately that's extortionately expensive at the moment, largely because of global demand for the necessary consumables, and you have to forgive my son shouting in the background, but also because of the availability of the kind of manufacturers to produce the kits, as you can imagine, the machines, as you can imagine, everywhere in the world wants this at the moment, and it is quite limited in terms of manufacturing capacity and the availability of supply. So we are going to be putting in point of care testing. We have placed orders, and we will be doing that because it's the only way really to keep everybody safe and to help the NHS get back to usual business. But I think that our industry and innovation colleagues are doing a grand job in trying to find ways to work around this, and the strength of our life sciences in the UK and our research sector, I think, will be our saving grace in terms of solving some of these problems in the longer term. Unfortunately, because of the, you'll all have seen in the press, because of the kind of market that we've got for equipment, is inevitably going to be constrained when everywhere in the world is after the same items. So we'd love to be able to do more testing, but we're doing a reasonable amount at the moment, and we have several thousand of our staff can get tested if they need to through drive-through centres, and if they become symptomatic at work they can access testing locally as well. I'm trying to think if we've got any more questions. What do I think the NHS will look like in 10 years' time? Well, hopefully a distant spot in the mirror now. I think that the NHS will probably look fairly, I'd say fairly similar, in that I can't imagine we're going to have a lot of capital to make any massive infrastructure changes. But I think, hopefully, what I hope will happen is that people will recognise that hospitals are not safe places. I mean, they're safe places if you're ill, but they're not safe places to go to access healthcare. You know, you'll be exposed, you always were exposing yourself to kind of risk and noise and all this other stuff. They're places for people who are acutely unwell and they need to receive specialist treatment, and we're fantastic at that. But you know, that we should be able to support people at home as much as we can for things like, you know, whether advice needed or just a test is needed. And primary care is by far the strongest part of the NHS for supporting the health of our population at that level. So hopefully we will find that hospitals are not hugely big, but are big enough to support what our population needs. And then the thing I think is really nice about what's happened during COVID is the community response. So a lot of the time we've talked about how a lot of the problems which manifest as health problems or mental health problems could be symptomatic of other areas of society that could benefit from being stronger. And I think the sort of army of kind of support that's come out for our shielded high risk populations who are shielding at home, so the elderly, for example, or those who are vulnerable or high risk, I think has been really quite significant. I think we had quite a kind of individualistic approach to things before, and so that's what I would really like to see stick. And I'd really like to think of that people could benefit from greater kind of community, not necessarily geographical community, but whether it's online communities, strength and reinforcement for their well-being, and also could access more support, whether it's social support, volunteering, coaching, etc., which tend to be, if you to look at the root cause analyses of many things, particularly in terms of management of people with long-term conditions, those things make a huge difference. And that's not controversial. There's a massive evidence base to support that, and it is the kind of at the moment often within the demise of our voluntary services to support, and it shouldn't be. It should be kind of core business for all of us. So I think what in 10 years' time, if we've been able to capitalise on that, we should see many more people being supported to stay well locally through a network which involves their kind of local community, their primary care, other kind of I suppose patient and people organisations to support them, and the more we can do to kind of empower that and support that and bring that will help to people to stay well for longer, and we in the hospitals will be super slick and well funded and well equipped and fully staffed. That's what I'd like to see. Right, so have I finished my time? I've got 2 more minutes left, so if anybody wants to ask me anything in the last 2 minutes, then feel free. Otherwise, this is quite a strange experience, but I think hopefully it's been enjoyable for you. It's certainly been enjoyable for me, and nice to know that people have been interested in asking some questions. So I think I will say good night and continue to follow St Anne's online. I believe next week you're going to get a cooking demonstration, so hopefully that will be technically easier to get into than me trying to get onto my phone, but also it sounds spectacularly dangerous, so hope it all goes off okay. Otherwise I'm sure the John Radcliffe will accommodate anyone with any burns as a result, but I'm definitely going to be downloading that later on to get some tips. So tune in for that next week, and thank you all very much, and thank you so much for St Anne's for asking me to take part. I hope it's been enjoyable for you, and stay at home and stay safe.